Welcome everybody who is on this webinar series in the context of our healthcare professional platform we have developed here at Thalassaemia International Federation. And we are truly pleased and very privileged to have with us a very important for the history of cardiology in thalassemia and hemoglobin disorders in general through the years, Professor Malcolm Walker, who has been, if I am allowed to say the phrase, a pioneer, a founding member in all this story of development of the cardiac care of hemoglobin disorders. We've lived with him the progress in morbidity and mortality of cardiac conditions in thalassemia, which have been amongst the most important cause of loss of patients throughout the world and in the Western world as well. So we are very proud to have the very scientist, the very medical specialist with us, Professor Malcolm Walker, a dear collaborator of TIFF and friend. And thank you for being with us. Gadia, also our scientific educator, Gadia Bilidis is with us, who's administering the platform and is in contact with all our medical specialists that provide us very kindly these webinars. So welcome all to this webinar. And Professor Malcolm Walker, you have the floor. Following Professor Walker will be another dear friend and collaborator of Thalassaemia International Federation with a vast contribution in the cardiology, Professor Dimitris Farmakis, who will be giving his presentation videoed due to pre-recorded due to a commitment at this time of the day. So Professor Walker, the floor is yours. And once again, our deep gratitude for being with us.
Well, thank you very much for that introduction. You're far too kind, and I hope what I'm going to say justifies your very kind comments. Are you able to see my slides?
Yes, we are.
Yes.
Super. Well, essentially, I work in London, central London, at University College Hospital, and you'll see from the photographs the transition from actually, I'm proud to say that was a building where I first started working at UCH when I arrived there in 1987. That was the new building in 1906. On the far right is our more modern building, which we moved into the new hospital in 2005. And then my own institute, which I helped co-found, the Hatter Cardiovascular Institute, we moved into the bespoke buildings where I undertake both laboratory-based and clinical research. So that's where I am. I've been looking after patients with thalassemia, I would say properly, with a real interest that came on in about 1990 due to there being a very significant cohort in our part of central London. Plus, I was very, very fortunate to be appointed in institutions with some extraordinarily active and important hematologists, both in my own hospital at UCH, but also in our next door hospitals at the Whittington. Specifically, I'm talking about Dr. Beatrix Wonke, who'll need no introduction to this group, who I'm still in contact with despite her being retired. And I should say to everybody, it's Beatrix Wonke's fault, if fault can be put anywhere, that I got involved because she kept referring me patients. I don't have any conflicts of interest here. I have in the past had a lecture honoraria and travel support from a number of companies. This is a very important historical slide, again by a colleague from UCL, UCLH, Bernadette Modell, published in the year 2000, and it's a historic data looking at the outcome of all of the thalassaemia major cohort in the UK. And it makes the point that with the red graph, I've redrawn this from their Lancet paper for clarity. If you do not transfuse thalassaemia major patients, and this is the English cohort, they all died by the time they were 7.5 years of age. And then with the bluey green graph, you will see that it became clear that if you transfuse these infants, they were able to survive. However, as all of you involved in this care know, that in the early days of transfusion alone, there was then a terrible attrition rate, which again here for this cohort who received only transfusion and no other therapy, they were all dead by the time they were 25. Now, the point of this slide as a cardiologist is that the majority of those deaths are due to accumulation of iron in the tissues, and of course, specifically accumulation of iron in the heart. So well known that if the iron is allowed to accumulate through transfusion, then the tissues get loaded, and that causes premature death. The mechanisms, this is a good review by my colleague John Porter, published a few years ago now, but it gives a very good cartoon explaining that the mechanisms by which iron can damage cells everywhere, but the heart specifically, depend in part on the generation of reactive oxygen species. And then there's a lot of different methods: DNA damage, organelle, that is mitochondrial damage, lysosomal fragility. Anyway, you end up with cell death. It's a bit contentious whether with the thalassemia you get much fibrosis, and I would say that actually you do not get much fibrosis. Now, the Italian cohort will disagree with us, but we see it very rarely, although things may change in the future. Nevertheless, the potential is there for these mechanisms to generate fibrosis. As you hematologists would know, the heart is one of those organs where you are born more or less with a finite number of cells. And historically, it has always been thought, and it's probably true to a large extent, that you have a cohort of myocytes when you're born, and they have to survive your entire life. So loss of myocytes, for whatever reason, can have very, very significant implications for the patient. And here's an example of an implication for the patient. This is a real example some years ago, a young woman, aged 27, thalassemia major, and this, would you believe, was a routine visit. In this little cine panel here is a standard bedside echo, which we did in our clinic, and we're horrified to see that, I hope you can see here, this bit here is the left ventricle, this is the mitral valve. And it doesn't take much imagination to see that that is not pumping well at all. And I know you hematologists like numbers, and the number to assess pumping capacity for the heart, one number is the ejection fraction. And this young girl's ejection fraction was 15%. She had very little in the way of symptoms. She was a bit more breathless when you asked her, and she had been developing some swelling of her abdomen and ankles. But, you know, she didn't have much in the way of complaint, but this heart was terrible and scared us, so we admitted her immediately. Now, she was part of a cohort that we later published when I was working with Professor Dudley Pennell, who was my registrar at the time in my clinic, and got his initial experience in patients with thalassemia from my clinic before he was appointed as the head of the MRI unit at the Brompton. We started some early collaborations with a young doctor called Lisa Anderson. And this is a simple cartoon from a paper we published in the Lancet showing that cardiac function as assessed by the ejection fraction rises as you treat, in this particular cohort of seriously affected patients, with 24-hour-a-day, 7 days a week intravenous deferoxamine. And you can see that by giving chelation 7 days a week intensively, you could improve function very significantly. And the purple on the right here shows cardiac dimensions. So the heart had enlarged in response as it was failing, and then gets better across time. So intensive chelation could improve cardiac function. It's obviously very important to establish that, because that gives us a rationale and a basis through which we need to treat patients. And so here's an example affecting this particular girl. So here you have her echo when she appeared in clinic, and this is her echo actually in another clinic 14 months later. She had been an inpatient, I think, for about 10 or 11 days before she was established on intravenous deferoxamine plus oral deferiprone. Now this echo on the right is not just a little better. This echo on the right, you show it to any cardiologist and they would say it was normal. Yes. And this, to me, was one of the fundamental turning points, if you like, in my career. It's incredibly uncommon to have heart failure. It's pretty uncommon in young people, and that's a tragedy in itself. But this progression from terrible disease to potential normality is spectacular and really piqued my interest. This young woman is still alive today. She went on to have a career. She's had children. She has done incredibly well. So it's not just a slightly better life, but a normal life is possible if you can do that. So where were we? Up to the year about 2000, what I found myself, we had regular transfusions and we'd had chelation for some time. But nevertheless, the reason I got involved was that Dr. Wonke in particular kept referring patients to my clinic who had gone into heart failure or were about to go into heart failure. And in my clinic, as elsewhere, in the 1990s onwards, we were seeing about 30% of those youngsters dying acutely of heart failure or acute sudden deaths, arrhythmic, related to poor heart function. Now, they'd already done the difficult bit, got themselves to teenage and early adulthood, and in a small community of patients, this was psychologically deeply traumatizing, a real tragedy, and deeply affected all of us involved in their care. Despite all the high tech, and I pride myself as being a modern cardiologist with all the tools at hand, a heart failure, once it's as bad as this young woman here, survival, even in our hands, we thought we knew what we were doing, was less than 50% in those that came in. So a real problem, and we desperately needed some kind of way of detecting people at risk of going into heart failure. And this is where the interest with Dudley Pennell came along, because he was developing this new technology of the cardiac MRI scan. And just a few things in principle. The cardiac MRI gives images largely related to hydrogen ions or water in any tissue. And when you produce a picture, you have what's called echo time. So across time, the picture will degenerate. This is a cross section of a liver. And you can see the beginning of the echo times as you collect the images, it is light in color, but with later echo times, it goes dark. And you can plot the intensity of the light, so it gets darker, and it gets darker along a mono-exponential curve. Not only that, you can analyze these curves, and you can get a time constant for that curve. And there are three natural time constants, T2 star, T2, and T1. And they are greatly altered by the amount of water in the tissue, or specifically if you have iron or any magnetizable metal, it will alter the rate, the speed at which the signal decays. In principle, with iron there, it gets darker very much quicker. So we set about with Lisa Anderson looking at T2 stars in patients with thalassemia. There's a lot of confusion out there, and it was our fault in a way, because we fixed on the time constant, we would have been better looking at rate constants, which is just a reciprocal of the time constant. For reference, a normal T2 star in a population without any iron overload is about 30 milliseconds, and a T2 about 50, and a T1 about 1,000 milliseconds. And that gives you, if you do the reciprocals, you get the R values for the same thing. So just a few principles. The liver has more, what we mean by more variable, the tissue. There may be iron, particularly in different parts of the liver. So there's a lot more variability in the tissue. Iron very strongly alters the signal. It alters the T2 star more than the T1, sorry, more than the T2 and more than the T1. And there are some, you should know, aspects about reproducibility. T2 star was probably a bit better than that if you do it well, but maybe plus or minus 10%. T2 is a bit better, and T1 is even better than that. If the signal decays very rapidly, as you get a lot of iron, it's difficult to measure, so the accuracy goes out of the window. So be careful. With very, very low T2 stars, very difficult to be accurate. We have, thanks to a very beautiful study done by Dudley Pennell and his team, physical calibration. That is, we had some sad cases where the post-mortem hearts of patients with thalassemia who'd had MRIs in vivo were compared to MRI T2 stars in vitro, and calibration was provided for T2 star. There's an increasing use of bigger and faster magnets, 3 Tesla, which is twice as powerful as the 1.5s that we did this work on. And that makes great difficulties. T2 star is very difficult to measure with 3T. T1 is probably better, but we're exploring that. So what happened? Again, early on, working with Dudley Pennell, we published again another of our combined research fellows, Dr. Tanner, showed here that you could plot across individuals being treated, this time in a study of a placebo versus deferriprone added to deferoxamine, and you could show that cardiac function improved better with combination oral and intravenous therapy, and that improvement in function followed the improvement in T2 star. Again, just to emphasize, the higher the T2 star, the less the iron. And that allowed us, again, with Dudley Pennell, again, another Paul Kirk, a combined research fellow, were able to generate this diagram, which tells us a sort of relationship between the T2 star and the subsequent development of heart failure. So that with low T2 stars, with a lot of iron, the risk goes right up. So the lower the T2 star, the higher the risk. And if you have a T2 star under 6 milliseconds, in this particular group that we studied some time ago now, the risk of going into clinical heart failure was nearly 50% within a year. Now remember that acute mortality is about 50% if you go into heart failure. So really serious. And this showed us that using the T2 star, you could predict these people with a T2 star over 20 who didn't seem to get into trouble, at least not immediately. And these people who were in imminent danger of decompensating and dying. That's really important for a clinician. You then, for the first time, have a tool to tell your patient, look, you're at real risk, whereas the other patient, you know, things are going all right, we'll carry on. And when you are giving patients extremely difficult treatments to comply with, because they're painful, they're difficult, they disrupt your life, they make you feel unwell sometimes, patients need that feedback. And it's using that kind of feedback that I think improved our ability to treat patients massively. Again, this is UK data published by Bernadette Modell and her colleagues, and essentially looking at the mortality of the UK cohort over 5-year periods. And it was in this period here where the MRI became into clinical use. In red were those deaths mostly related to cardiac decompensation. And so you can see immediately you have a tool that you can start predicting those people at risk. Clinicians respond, patients respond, and you get this massive reduction in mortality. So over 70% reduction in mortality. And Bernadette, who's a very important personage in the thalassemia world, attributed the greater than 70% reduction mainly due to heart iron load, can be attributed to the introduction of the T2 star and also having better treatments that we could offer our patients. This obviously is not, this is UK data, it's been replicated in Italy, in every other country where it's been looked at. So being a clinician looking after patients, if you have a tool that can measure the toxin, you're immediately in a better situation. And that's reflected with no new medicines at this point, just better treatment, better targeted treatment to the patients at risk. So we end up with certain standards, and the cardiac T2 star by bright blood is now the global standard. This is a bright blood, that's a dark blood. It's a technical thing because you can draw the edges more accurately with the dark blood techniques. A few take-home messages. A T2 star conventionally over 20 milliseconds is considered normal. It probably isn't. And actually over 28 milliseconds is now where we're heading. That is much nearer to having no iron in your heart. The other point that I would just emphasize, if you have very little iron in your heart, a change in T2 star of 6 milliseconds, let's say from 30 milliseconds to 36 milliseconds, is very little iron movement. Clinically, it's useful, it's good to see, it's the right direction, but the amount of iron involved is very tiny because these relationships are not linear, they're exponential. The converse is true. When you have a lot of iron in your heart, a change in 6 milliseconds from, let's say, 6 to 12 moves you from 50% risk of heart failure to probably a 10% risk of heart failure. So you've just got to bear that in mind, that the same numerical change has very different implications. So I'm going to talk a little bit, that is, if you like, history. I'm just going to talk very briefly for the last few minutes on current and future. I was part of an international panel, set up recommendations where the heart was concerned. And by this time, by the time we published this in 2013 in Circulation, it was true to say that all 3 chelators are effective at cardiac iron removal if you give them, and if the patient's able to take them at adequate doses, and if they take the prescribed medicine. And to get the best combinations is the key, isn't it? So that your patients can take the treatment. So you have to tailor treatment to the individual. And that is from there. And I'm just going to say, where are we today? This is the most recent prospective look at what is happening in the real world, published by Alessia Pepe in Italy with her colleagues. I'm just going to move this a bit, sorry, it obscures part of my slide. And what they're able to show, this is actually a group, largest group, nearly 200 patients with either deferoxamine, deferriprone, or deferrazirox. And it shows that across from baseline to review, which I think was on average about 4 years, forgive me, I can't remember, that the T2 star rises in each of the patient groups that were treated. So you're able, with all 3, this is monotherapy in this particular report, you're able to get rid of heart iron in your patients. And you know, obviously that's a good thing. When you look at function, there are a few differences. They are pretty small. There's an improvement in function with some, but maybe not as much with others. I wouldn't make too much of this at this stage, but there is a change in ejection fraction seen with deferriprone and deferoxamine, and perhaps less so with deferrazirox. These would be patients taking the older forms of deferrazirox, I'd emphasize. oops, sorry, move on. So combination therapy has been a very big development. Daily deferriprone plus deferoxamine can reverse cardiac cirrhosis, improve function, and is well established. And these are the comments that we made in that position paper. Combinations of the two oral chelators, now approved by the European Medicine Agency, are increasingly commonly used, and particularly outside of Europe, and for good reason. It's much easier to get patients to take tablets than to have cumbersome injectors and infusers. And there have been a significant number of international guidelines, and these are well reviewed by Professor Teja and his colleagues fairly recently. And I'll just summarize them. There are differences in detail for each of the countries where the heart is concerned. USA is a little bit of an exception, or they're changing. Significant cardiac iron load, suggesting deferriprone or combination. Impaired ventricular function, deferriprone or combination. I think these need to be updated, but there are a lot of guidelines around for different parts of the world. So I just want to talk a little bit about the future and some developments, because despite T2 Star being brilliant, here am I in a very, or used to be, a very rich country as a clinician, and actually access to T2 Star can be difficult for me because it's expensive. The traditional T2 Star techniques can take 45 to 55 minutes in the scanner. It's difficult, but we get cross-charged somewhere between 300 plus euros per scan, so expensive. And the countries where there's the biggest burden of thalassemia are countries that often can ill afford this technology. And we've been interested with my colleague James Moon to start exploring different ways, perhaps of improving accessibility. And we struck upon using the native T1 signal, and I won't go into the theories behind that, but one of the reasons that with native T1, you can get an instantaneous view of iron on a screen, which is very good for a large group analysis. So green, no iron, blue, a lot of iron, and intermediate here. And so the techniques were developed by colleagues in Oxford and elsewhere. But what we did with James and colleagues, we took this technology to Thailand as a proof of concept. And we were able to do this, what we termed at the time, ultra fast, although it's now termed rapid. And we did 120 MRI scans in thalassemia patients over a weekend, so Saturday and Sunday, 120 scans. And we're able to show that you can do that and get very good scans in less than 10 minutes. So proof of concept was there, that we were able to do it. The average scan time in Thailand was 8 minutes. And then we proved, because we did both T2 Star and the T1 map, that the two gave very consistent, reliable results. So here we have now a scan that requires minimal number of breath holding, can be applied to much younger individuals who find it difficult to hold their breath the time necessary for a T2 Star, and potentially by reducing the time, increasing the numbers and decreasing the cost. I'm just going to introduce you, because I've not published this yet. We only just finished the data gathering just before COVID came in and we had to leave India. So I took this technology to India in something called the UMIMI project, and scanned 104 patients in 2 centers over 2 days. We didn't have T1 mapping because their magnets are very old. So we had to use old GE and Siemens scanners, and we used T2 Star, and we looked at cardiac function and lots of other things too. We managed to do scans in under 12 minutes, and we used that data. So I was interested not just in getting pictures, but in seeing we can affect patients' lives. So I used the generally published guidelines to base recommendations on what they should be doing for their chelation on the basis of the MRI image achieved in 12 minutes. And then we plan to go back after 14 months. And in fact, we just did that and completed it at the end of February and just got out of India in time. This is one of the cohort groups in one of the hospitals in one of the districts that we looked at. And, you know, the initial findings were interesting, that cardiac iron load was present in 40% or 36% in one center and 20% in the other center. Now that's interesting because then you can have benchmarks to see what is different between the two areas. Severe iron overload, defined by a T2 star less than 10 milliseconds, was more equal, 15 versus 10%. Liver iron was common in the Indian cohort. About 40% in both places had severe liver iron. So not many differences between liver iron in the two centers, whereas the heart iron was quite different. And from this, 47% of our cohort were pretty good. Good liver, good heart, happy with what was happening to them. But that means 53% of this group, over half, we recommended an increase in chelation. Now, we didn't mandate what the increase was, but we heavily promoted guideline-based changes. And so what we concluded to that point, we've just done the second analysis of all the patients, so that will come yet. I'm not going to present that today. So 53% were recommended to change their treatment, and we'll see what difference. The last couple of slides, are there any other developments apart from MRI? Well, this is the old ECG machine that used to be used in this hospital. We've now taken to using, particularly when we went to India, this very beautiful little machine. Doesn't require any electricity outside, just your iPad, and you can get a 22 lead ECG. It's also very cheap, very good for screening. However, a normal ECG does not exclude iron load, although patients with heavy iron load tend to have abnormal ECGs. The other way around is not always true. We've been using increasingly these stick-on ECG patches that give you a reading. This is a 14 days of continuous ECG. This young man, that's not him, this is a model, but this young patient who's recording his hair, you can see their heart rate goes along, goes along. And on the early hours of day 10, the heart rate goes up for 4 hours and then down again. And when you expand that, that was a bump of undiagnosed atrial fibrillation. That is important because it's a cause of stroke. This guy had never been able to capture any arrhythmias any other way. So you can pick up things that you'd otherwise would miss with this new technology. And we've been looking at this in our clinic, and this is the atrial fibrillation prevalence in our thalassaemia cohort, nearly 50% in the over 40s. And this is compared to the national age-matched. So there's a big problem in thalassaemia, and that's on its way, folks, for all of you. There are new ways. All of you will now have availability of these cardio devices onto your smartphone. And of course, the new watches that also can record diagnostic quality ECG. So we'll pick it up more easily, more often, more accurately. Briefly about the echo, just to get you used to the idea, the ejection fraction, which you all thought you understood, is latent changing. The measurement is variable. You can be much more accurate if you use highly important techniques. There are some better measurements, and I'm not going to go into them because we've run out of time. I'm just going to move on. So in general conclusion, there's been an improvement in the heart outlook for thalassemia patients. The MRI scan has greatly improved the precision of diagnosing heart risk and the faster sequences. I didn't tell you, but that means that our MRIs go down to under $100, probably about $60 a piece, which then becomes a realistic prospect for many developing nations. Using conventional tools, using them better, using newer devices, we'll get more information. And the improved outlook is better treatment with a selection of chelators and combining them in many patients. And as they get older, new problems, atrial fibrillation, heart failure with preserved ejection fraction, and pulmonary hypertension are emerging. And we've got to be very vigilant that we don't let all the benefits that we've achieved get lost. And we must not let our patients undergo that evolution. I'm sorry if I've been a bit long. I'm out of practice. Forgive me. And if there are any questions, I'll be happy to take them.
Και τώρα να πει καμιά ερώτηση να μου κάνει. Κάμε το όμως καμιά. Τουλάχιστον για τα guidelines. Okay.
Thank you very much.
Thank you very much. It's been really educational, and for me, very educational.
I think we wait for questions after the next.
Yes, after the next video. Thank you so much.
Να μιλήσει για το φαρμάκι.
Είπαμε τα.
Good afternoon. Welcome to this series of webinars organized by the Thalassaemia International Federation. Today we're discussing about heart disease in thalassemia, and I will focus particularly on heart disease in patients with thalassemia intermediate. So heart disease has been the leading cause of mortality in patients with thalassemia for ages. Today we are facing a new era of dramatic improvement in patient survival that tends actually to reach that of a normal lifespan in patients that are regularly treated and followed. So the interesting thing about survival in patients with thalassemia in terms of heart disease is that the decline of mortality observed over the past years actually is pretty much the same or parallels exactly the decline in cardiac mortality, so the decline of death due to heart disease. And this is very, very impressive. This comes from a thalassemia cohort from Greece, very large cohort. And under notes, the stresses the importance of heart disease in patient survival. And this improvement in survival and also in heart disease was accomplished by the advances in thalassemia therapy, moving at the beginning to regular blood transfusions, then to iron chelation, then to MRI-guided chelation therapy, combined chelation therapy, and multidisciplinary care. So what was the picture before the introduction of regular blood transfusions? Then only 1/3 of patients were able to make it through adolescence to adulthood, and all patients, practically most of the patients, died of heart disease, particularly heart failure because of high cardiac output, the so-called high output heart failure, which is caused by long-standing severe untreated anemia. Then we moved to a new era of regular blood transfusions. Back then, there was also cardiac mortality. Again, heart disease was the leading cause of mortality, but this time not to high output heart failure, but because of heart failure caused by a ventricular dysfunction caused by iron overload. So we had the so-called iron overload cardiomyopathy that led to ventricular dysfunction, diastolic, and most importantly systolic, with the typical form of dilated cardiomyopathy, so left ventricular dilatation with depressed left ventricular contractility. Then after that, there was the era of MRI. So MRI came in to offer us a wonderful tool to detect the tissue content in terms of iron load. So we were able to monitor the content of iron in the heart and in the liver. So the lower with this T2 star value, so the lower the T2 star value, the higher the tissue iron content, and the higher the risk to get heart failure and arrhythmias. And this was very, very useful in order to guide chelation therapy. And back then, there was also the development of combined chelation therapy, which was actually able to manage severe cardiac iron overload. So even cases with heart failure and severe left ventricular dysfunction because of iron overload were able to have an improvement in cardiac function and a reversal of heart failure due to combined iron chelation therapy. So the so-called MRI-guided chelation therapy improved dramatically the survival of patients with thalassemia. So we moved to the current era where heart disease is actually minimal or not at all present, and we have in regularly treated patients, and nowadays it is the first time that heart disease comes at the second place in terms of mortality, with giving its place to liver disease as the top cause of mortality. And what we observed in patients with regular treatment in terms of thalassemia major this time was in this study was a low incidence of heart failure and a low incidence of systolic LV dysfunction, and things they are even better than that was published 15 years ago. So the form of disease-specific therapy in terms of transfusions and iron chelation determine the form of heart disease in patients with thalassemia. So we can tell that disease-specific therapy determines heart disease, and heart disease in turn determines the overall survival of patients. Now, this is actually the spectrum of cardiovascular disease in patients with thalassemia. We have cardiac complications and also vascular complications, but let's move specifically to patients with thalassemia intermediate. So these are two chest x-rays, the x-rays of two patients with thalassemia intermediate, rather typical ones.
Okay.
Dysfunction of the left ventricle was preserved, in contrast to the cases with iron overload cardiomyopathy, but we had a very high prevalence of pulmonary hypertension, actually severe pulmonary hypertension, like in this case. A study of 110 patients with thalassemia intermediate. This was actually the largest cohort study of patients with thalassemia intermediate in terms of cardiac evaluation. Back then, it was actually the thesis of my PhD. And we observed that patients with heart failure, they all had, as the case I showed you earlier, they all had preserved left ventricular contractility. They all had high cardiac output developed due to anemia. And at the same time, they had severe pulmonary hypertension. Up to 60% of patients had pulmonary hypertension, which was actually age-related. So the higher the age, the higher the prevalence of pulmonary hypertension. And we observed the same findings in a later study comparing two cohorts, one with of thalassemia major and another one of thalassemia intermediate. Again, we had heart failure in both cohorts, but in the case of thalassemia major, heart failure was associated with left ventricular systolic dysfunction in the context of iron overload cardiomyopathy, while in thalassemia intermediate, heart failure was associated with pulmonary hypertension. Exactly the same findings in two other cohorts, one from Lebanon and another one from Italy. So again, patients with thalassemia intermediate tended to develop pulmonary hypertension and a less prevalence of a lower prevalence of cardiomyopathy, while patients with thalassemia major exactly the opposite. So higher prevalence of left ventricular cardiomyopathy and a lower prevalence of, much lower prevalence of pulmonary hypertension. So again, heart disease and thalassemia intermedia was associated with pulmonary hypertension and not the typical left ventricular cardiomyopathy seen in patients with thalassemia major. What is the pathophysiology of pulmonary hypertension in patients with thalassemia, particularly patients with thalassemia intermedia? It is complex, but one can define four main domains. First, the main disorder, the pathophysiology of the main disease, which is actually hemolysis, and then high output state because of long-standing anemia, and with a lower contribution of pulmonary disorders and left heart disease. Now, in this study is very interesting because it shows, in terms of epidemiology, the determinants of pulmonary hypertension in patients with thalassemia. So we have aging. The higher the age, the higher the risk of getting pulmonary hypertension in patients with thalassemia intermedia. Again, splenectomy is associated with a 4 times higher risk of pulmonary hypertension. And then, interestingly, what lowers the risk of getting pulmonary hypertension in thalassemia intermedia is actually the disease-specific therapy. So regular transfusions, hydroxyurea therapy, and iron chelation therapy reduce the risk of having pulmonary hypertension. What about starting blood transfusion? Does this addresses the risk of getting pulmonary hypertension? Well, not completely if transfusions are started late. In this cohort from Italy, 88 patients from Italy with thalassemia intermedia, there were started on blood transfusions at the mean age of 38 years. And the outcome in terms of pulmonary hypertension was not a reduction in the prevalence of in the occurrence of pulmonary hypertension after the onset of regular blood transfusions, and neither was the remission of pulmonary hypertension in terms of after the onset of regular blood transfusions. So this tells us that blood transfusions may not work in terms of pulmonary hypertension prevention if they are started late. Besides heart disease in patients with thalassemia intermedia, we have also vascular disease, which is actually pretty much frequent compared to thalassemia major. So in this study, in a large cohort of patients with both thalassemia major and intermedia, we have a significant occurrence of prevalence of venous, particularly venous thromboembolic complications that were 4 times higher actually in patients with thalassemia intermedia compared to those with thalassemia major. So elderly patients with thalassemia intermedia are associated, have a tendency to develop venous thromboembolic complications. Actually, the same finding was seen by the 2 aforementioned cohorts from Lebanon and Italy. Again, a high occurrence of thromboembolic complications not seen in patients with thalassemia major treated regularly. And this was actually pretty much related with the presence of extramedullary hematopoiesis seen only in patients with thalassemia intermedia, that also stresses the importance of disease-specific management for the prevention of cardiovascular complications. What about the pathogenetic background of vascular disease in patients with thalassemia, particularly patients with thalassemia intermedia? We have a functional component that is activated by the main pathophysiology of the disease, which is actually hemolysis. So hemolysis leads to an increased nitric oxide degradation and a reduced nitric oxide synthesis, and nitric oxide deficiency is actually the basis for endothelial dysfunction. But at the same time, we have also a structural component. So the elastic tissue of the vessels, particularly in patients with thalassemia intermedia, and this gets worse with aging, seems to have a structural abnormality, which is actually pretty much similar to that observed in hereditary pseudoxanthoma elasticum, inherited disorder of the elastic tissue. So we called that thalassemia-related or acquired pseudoxanthoma elasticum, and this comes with extensive vascular calcification, with valvular calcification here in the mitral valve or the aortic valve, sometimes causing even severe aortic stenosis, and also it comes with skin and ocular abnormalities that may also cause vision problems. Patients with thalassemia intermedia, particularly of advanced stage, should be monitored for this kind of lesions. So, to conclude this presentation, what is the measures to prevent and manage effectively the cardiovascular complications in patients with thalassemia in general? So we have first the disease-specific therapy, so the hemoglobinopathy-specific therapy that will address the pathophysiology of the disease. This means transfusions, timely onset transfusions to manage anemia, chelation to manage iron overload because of the disease itself, but also because of transfusions, and multidisciplinary care to manage the multi-system complications observed in these patients. And besides the hemoglobinopathy-specific therapy, we need to treat comorbidities like hepatic disease or endocrine complications that also contribute to the development of heart disease. In the case we have cardiac complications, we need to address them effectively and timely, and at the same time, in order to be proactive and actually prevent rather than treat cardiac complications, to have regular cardiac follow-up that should be at least annual, on an annual basis for all patients with thalassemia, including those with thalassemia intermediate, or at shorter intervals if there is any form of cardiac disease. And the last point is lifestyle choices that promote actually cardiovascular health, like smoke cessation, regular physical activity, and weight control. Now, what about the today challenges in the management of thalassemia patients, including heart disease? So we have an aging thalassemia population. Actually, this is a great achievement of modern therapy. So in this cohort from a thalassemia center in Nicosia, in Cyprus, we can see that the majority of patients are actually in their 40s. The median age is around 46 years, and only 7% of patients are aged less than 20 years, while about 20% of patients are older than 50. This is a great achievement, of course, to have this aging thalassemia population, but at the same time, it comes with some consequences in terms of heart disease. So the higher the age, the higher the risk of developing age-related heart disease, and heart disease in the general population is actually pretty much age-related. So with the aging of the thalassemia population, we may observe in the following years, in the years to come, an increased risk of age-related heart disease, like atrial fibrillation or coronary artery disease or aortic stenosis or even stroke and so on. So in order to address this, we need to change our strategies in monitoring and following this aging thalassemia population. The Thalassemia International Federation published some time ago this position statement, focusing on the changing epidemiology of the disease. And we proposed a number of measures that should be, of actions that should be undertaken in order to address the needs of this aging thalassemia population in terms of increasing the awareness among patients, families, but also healthcare professionals, understanding better the epidemiology of aging in thalassemia, updating our clinical protocols in order to monitor for age-related complications, not only in terms of heart disease, but in all systems and organs, and also adopt preventive strategies that help us address the risk of developing age-related complications like lifestyle modification and other measures. And with this, I conclude my presentation, and I invite you all to join Thalassaemia International Federation to learn more, but also be able to contribute. Thank you very much.
Thank you very much, Professor Farmaki, as well. And this has been really very interesting, and we hope that this was found very interesting by a lot of our participants. Michael Angestignodis is here with me, and apologies for not introducing at the very beginning. A medical advisor, chief, and the colleague of many of you. Michael, would you undertake the questions, please?
Yeah, Malcolm, it's since Dr. Farmakis is not with us, alive and well, most of these questions will have to be referred to you.
Hopefully, it's okay.
You can press on this one.
So,
questions and answers, you can read.
There is questions and answer where you can read as well, but what is losses of iron overload on organ special heart? I don't know what the question is about. Probably he or she means how we can lose iron overload from the heart. What are those special measures that can be used?
I think he's referring to the possible effectiveness of removing iron from the heart.
Which tools we use for effective? Unmute, please. Unmute your microphone. Yeah, thank you.
Okay. Thank you for that. Okay, I mean, I think the answer is at once very simple and secondly, much more difficult to achieve. All chelators, as I said in my talk, are able to remove iron from the heart if they're taken at recommended doses regularly without pause. And there are few other special interventions that are proven. So essentially what the clinician has to do is to ensure that the regime of chelation is able to be adhered to, and if not, to make changes so that patients can adhere to them. There is no question that combinations, there's proof prospectively from a trial that combining deferoxamine with deferriprone speeds the loss of iron from both liver and heart. There is lots of anecdotal data, but no prospective trial data as such, but lots and lots of experience data all over the world that combining both oral chelators is a very effective policy when a single chelator has not been effective. But I would emphasize, it's mainly that the patients actually take the medication, are able to take it at sufficient doses regularly. What appears to be the worst scenario is having periods of holidays from chelation when whatever good may have been done by removing tissue first, and they have days or weeks without any chelator. So if you have combinations, it's sometimes easier to have that conversation with patients. You know, the days that you can't take X, make sure you have some Y on board. Those sorts of approaches.
Thank you, Professor Walker, but this has taken us to a very important point and concern on behalf of Thalassaemia International Federation, which is the accessibility of the patients to appropriate and continuous chelation regimens, because that's the major problem across the world, outside the Western world, is the continuity of the chelation, the availability and accessibility to our patients. And hopefully this is going to improve with the transition that the healthcare systems are undergoing in the developing economies towards universally coverage based healthcare systems, because now most of them are out of pocket, and accessibility and availability are up to the pocket, the size of the pocket of the parents and the patients in many of the countries. So we are really concerned, because now we have the means to keep our patients alive, to keep them well in health, to have quality of life, to have aging, as Dr. Formaitis has pointed out. But the first thing is to ensure that they have at least the basic drugs on a continual basis. So going on to the question is, what is...
There's one other aspect, however.
Yeah.
Supporting patient adherence, even when all the chelators are available. Supporting patient adherence
is very important as well. Absolutely. What is the role of regular exercise in reducing cardiac risk in thalassemia patients? Is there a role? And if there is a role, what's the extent of the role?
We don't have any numbers to put on that, but it is generally true. The more exercise you can do, the better. You've got a condition which does put an extra strain, if you like, on the heart, and therefore the fitter you are, the more likely you are to be able to ride those particular problems ahead. So the difficulty with my aging population, the median age in my clinic is over 40. Many of them now, the biggest morbidity, or one of the biggest morbidities, is bone disease. So you have to allow and prescribe exercise that does not exacerbate a tendency to osteopenia and osteoporosis. So you have to perhaps sometimes take advice. So I'm not going to put a number on this, but
no.
The more the better, mixed strength and endurance, but be aware that with bone changes, you have to moderate and do exercise that patients can do safely.
Absolutely. Any antioxidant that can help the heart?
Simple answer, not proven, no.
Not proven. And we must say this, that not proven, because there's a lot going on and we need to go ahead with documented and evidence-based suggestions. Well, thank you, Professor Malcolm, for your informative presentation, but can you kindly guide us, what is the treatment steps for HFpF apart from chelation therapy?
This is heart failure with preserved ejection fraction.
Yes.
It's a common problem, not just in the thalassemia world, but throughout cardiology as all of us age. And it is essentially a stiff heart. The ventral becomes stiff. So the pumping performance is good, but relaxation is poor. Again, the answer is quite simple and rather depressing. There are no pharmacological treatments known for any form of heart failure with preserved ejection fractions. You use diuretics to deal with edema. You treat other risk factors like high blood pressure, not usually a problem in the thalassemia population. I believe that we see this also in our sickle population, that the anemia is deeply important, and Professor Farmakis emphasized the high cardiac output state. So I think trying our best to diminish that may well be helpful in the long term, but there are no specific therapies for HFpEF.
Okay, thank you. Michelle Abi, board member of TIF, yes, can you read, thank you for the excellent webinar. Can you comment on the value of having strain option in the echocardiography for thalassemia patients?
The newer parameters like strain, which are slightly less intuitive, they're more difficult, but they are proving to be beneficial. We published in the European Heart Journal and some data looking at tissue Doppler imaging analysis. So more sophisticated measures give you earlier warning. In the cohort from India, we have seen changes in strain that predate changes in ejection fraction. So strain is an important parameter in every aspect of cardiology, not only thalassemia. It appears to give us earlier warning and is more sensitive to change. So it should be something that is adopted as part of the analysis of cardiac function, because it will give you earlier warning of change before the ejection fraction falls.
There's another question about, sorry, I see one on pulmonary hypertension.
Threshold
How
of
it's diagnosed.
Huh? Where are you? How to diagnose pulmonary hypertension in thalassemia?
The tried and tested way is with echocardiography, high quality echo, looking at the jet of blood that goes backwards through the tricuspid valve. If you've got a good image and a good technique, you get very accurate estimates of pulmonary arterial pressure from what's called the tricuspid jet velocity. 2.5 to 3 is borderline. Over 3 is significant pulmonary hypertension. Under 2.5 is unequivocally normal. So we monitor this routinely in our sicklers and our thalassemics.
The other question comes from Iran. Is the normal threshold of liver T2 more than 30 milliseconds? We have updated in our center in Tehran based on the note from Professor Pennell.
Well,
but do we measure liver iron content still with T2 star? Don't we use the LIC?
It depends on what you have available. You certainly can get direction of travel, and you can certainly, I wouldn't get too hidebound, depending on the technology you've got available to you. Essentially, you need to know, do they have a lot of iron, a middling amount, or very little or no iron? You know, 40% of the group that I looked at in India had severe iron, no matter how you look at it. So yes, more accurate techniques give you nuances, but don't abandon what you get from the older techniques that give us an insight as to whether there is a problem or it's less likely. If you're aware of the potential errors in your measurement, you can then adjust for those. So T2 star tends to underestimate liver iron. But you know, if you know that, then you don't take the number in front of you necessarily at face value. You interpret it in the clinical context.
He's talking about 30 milliseconds. Can you comment on that?
17 is the one that we take as our upper one. You know, so I don't use 30.
Yeah. Okay.
I don't know where that comes from.
I don't know where that comes from, because I think that's a cardiac 3 milliseconds.
Correct.
Probably.
Correct. We're talking now something nearer 28 milliseconds and above is normal for cardiac.
For cardiac, but not for liver.
Liver 17 and above.
17 and above. So the other one. Is it an accepted liver threshold? Is there an accepted liver threshold worldwide? We have scored, what is it? We had some resistance from hematologists, and first we changed the liver threshold. So they are concerned about some standard, numbers of what we can call worldwide threshold. But as you very well pointed out, it depends very much on the technology used, obviously.
Yeah, I would be careful what I say here. And having, in some respects, got the measure of the heart, we do need to now concentrate on the liver, I have to say. And the reason there's this discussion is that those thresholds are changing in the knowledge of, of patients getting older. And so it seems your capacity to manage lower amounts of iron in the liver deteriorate as you get older, perhaps not surprisingly. So Whereas previously we were quite relaxed about it, we're now not relaxed, and it's clear it's a very, very important part of the whole body iron burden.
So thank you so much. Let's concentrate on the last four and hopefully they're short, Professor Walker. Why left ventricular ejection fraction in MRI is often higher than conventional echo done by cardiologists? Which one is more reliable?
There is a lower coefficient of variability using MRI. It's the edges of the tissue are easier to measure in one technique than the other. And it's basically just that the images tend to be clearer. Differentiation between blood and muscle in many people is easier with MRI than with echo.
What are the recommended cardiac tests for thalassemia major patients? Well, just for me to answer, not as a specialist, but I think that guidelines should be looked into. And there is a whole chapter on cardiac tests for thalassemia major patients, and I think that should give at least the basis for the cardiologists who are in the multidisciplinary care of these patients. But the answer is yours, Professor Walker. What are the recommended cardiac tests?
Well, starting at the top, the MRI is the basic one. If you get nothing else, if you can get that, that is really useful, but you don't need to repeat it. It depends on how heavily iron overloaded and what you're doing to the patient. That doesn't need to be repeated terribly frequently. The echo gives you insight. However, it can miss iron overload because functional changes occur late, unless you're using the more sophisticated tools such as the DTIs and the stress measurements. Echo is the only tool to follow the development of pulmonary hypertension. The ECG is useful for arrhythmia detection, is useful for subtle changes, particularly development of pulmonary hypertension, but a normal ECG does not exclude severe iron problems.
Okay. So, which is the other one? How to prevent
atrial fibrillation
and pulmonary hypertension. What test do you recommend?
Well, there are two questions there. How do you prevent it and how do you diagnose it? I think we've answered how do you diagnose it. How do you prevent it? Well, if I knew that, I'd probably be sitting in my cottage in the Swiss Alps with my feet up. It's not easy. You prevent it by good treatment. So I'll hand it right back to you guys. I think you need to be sure. The atrial fibrillation that we see is not related to iron overload today. It is related to iron overload 20 years ago, and it is related to diabetes. So looking after the patient is the best way of preventing atrial fibrillation occurring in later life.
And the last one, is mild hypertension common in thalassemia major? What is the cause? Any recommendations?
Very uncommon. Look for a cause. If you've got hypertension, it's not common at all. I would be very careful that their renal function is normal.
Okay. Well, thank you very much, all the participants, for being with us. This webinar presentations will be on the website. Any questions you can refer to Tim will be referred kindly to our experts who have kindly undertaken to give their presentations and their knowledge and experience to us. It will be part of the healthcare professional platform. Please take and have a look and take the healthcare professional platform of TIP. Give us your suggestions, which are welcome. We are very eager to continually upgrade and update our platform. The last word goes to our scientific educator, Kadia Belidis.
Thank you to both our panelists. For our participants, as Dr. Eleftheriou has said, please contact us to take a look at our healthcare platform. We have not only a course for healthcare professionals, but we also offer a course for patients. So medical professionals, please recommend the patient course to your patients. And if anybody has any input or anything, please feel free to contact us. Thank you very much, Professor Walker, for sharing your insights.
Thank you, Gadian. And if I may add, it's very important for everyone to know that the platforms are being translated. The patient's platform has been translated into 7 different languages. So inform your patients that they have no difficulty in understanding. It's in 7 different languages. Thank you so much, Professor Walker, Kadia, Dr. Mike, and Nora. Thank you.
Thank you very much.
Andrula, Michael, thank you very much. Katia, thanks for that.
Thank you. Thank you.
Bye-bye.
Bye-bye. Thank you.